Before we begin with the examination, take note for the common or concerning symptoms like chest pain, palpitation, shortness of breath like dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Let's review the three key vascular structures of the neck: the carotid artery, the internal jugular vein, and the external jugular vein. The carotid artery lies deep to the sternocleidomastoid muscle. The internal jugular vein lies beneath the sternocleidomastoid muscle, which and is adjacent to the carotid artery. Internal jugular vein is not normally visible. External jugular vein runs at an angle along the sternocleidomastoid muscle towards the clavicle. Jugular venous pressure. It is the measurement of the highest oscillation point, the meniscus of the jugular venous pulsation. It reflects the pressure in the right atrium, the central venous pressure. Examine both sides of the neck, then turn the patient's head slightly to the left, as the physical examination should be conducted on the patient's right. First, identify the external jugular vein and then the internal jugular vein pulsations. Look for the oscillation points along the sternocleidomastoid muscles between the clavicles and the angle of the jaw or just posterior to the sternocleidomastoid muscle. Now measure the oscillation point of pulsations in the right internal jugular vein. Extend a long rectangular object or a card horizontally from this point and a centimeter ruler vertically from the sternal angle, making an exact right angle. Measure the vertical distance in centimeters above the sternal angle where the horizontal object crosses the ruler and add this a distance of 5 cm, the distance from the sternal angle to the center of the right atrium. The sum is the jugular venous pressure. JVP measured more than 3 cm above the sternal angle or more than 8 cm above the right atrium is considered elevated or abnormal. For assessing the carotid pulse, first inspect the neck for the carotid pulsation just medial to the sternocleidomastoid muscle. Then place your index and the middle finger on the right carotid artery in the lower third of the neck and palpate for the pulsations. Press just inside the medial border of sternocleidomastoid muscle roughly located at the level of cricoid cartilage. Avoid pressing on the carotid sinus. Slowly increase the pressure until you feel a maximal pulsation. Slowly decrease the pressure until you best sense the arterial pressure and contour. Palpating both the carotid arteries at the same time can induce syncope. The contour of the pulse wave, namely the speed of the upstroke, duration of its summit, and the speed of the downstroke. The normal upstroke is brisk, it is smooth, rapid, and follows the S1. The summit is smooth, rounded, and roughly mid-systolic. The downstroke is less abrupt than the upstroke. Listen for the bruit arising from the turbulent arterial blood flow. Ask the patient to stop breathing for 15 seconds, then listen with the diaphragm of the stethoscope. Place the diaphragm near the upper end of the thyroid cartilage below the angle of the jaw, which overlies the bifurcation of common carotid artery into the external and the internal carotid arteries. Begin with general palpation of the chest wall. Using the techniques below, palpate in the second right interspace, second left interspace along the sternal border and at the apex for the heaves, lifts, thrills, impulses from the right ventricle and the 4 heart sounds. To palpate for the heaves and the lift, use your palm and or hold your finger pads flat or obliquely against the chest wall. Heaves and lifts are sustained impulses that rhythmically lift your fingers and are produced usually by enlarged right or the left ventricle or atrium. For the thrills, press the ball of your hand on the chest to check for buzzing or vibratory sensation caused by underlying turbulent flow. To palpate S1 and S2 using the firm pressure, place the right hand on the chest wall. With your left index and middle fingers, palpate the carotid upstroke to identify S1 and S2 just before and after the upstroke. For S3 and S4, apply lighter pressures at the cardiac apex. Locate for the apical impulses. Ask the patient to exhale and briefly stop breathing, then place the tips of your curved fingers in the third, fourth and fifth interspaces to palpate for the systolic impulse of right ventricle. If there is a palpable impulse, assess its location, amplitude and duration. Also palpate for the right ventricle in the epigastric or subside area. Auscultation of the heart sounds and murmurs. Take note for the oscillatory areas on the chest wall. With the diaphragm of your stethoscope, listen in the aortic area at the right second interspace close to the sternum. Note the cardiac rate and rhythm. Normally the rate is 60 to 100 beats per minute with regular rhythm. Auscultate the pulmonic area. Listen for the inspiratory splitting of the S2 into two components, A2 from the aortic valve closure and P2 from the pulmonic valve closure. During expiration, these two components are fused into single S2 sound. Then switch to the bell of the stethoscope. Listen along the lower left sternal border in the fourth and the fifth interspace. Then listen at the apex. To detect mitral stenosis, ask the patient to roll into the left decubitus position, which brings the left ventricle closer to the chest wall. Place the bell of your stethoscope lightly on the apical impulse. For detecting aortic regurgitation, ask the patient to sit up, lean forward, exhale completely and briefly stop breathing after expiration. Place the diaphragm of your stethoscope on the chest, listening along the left sternal border and at the apex, pausing periodically so that the patient may breathe. Palpating the carotid upstroke as you listen to the murmur helps you decide whether the murmur is systolic or diastolic. Systolic murmurs may be mid-systolic murmurs, pan-systolic murmurs, and late systolic murmurs. Diastolic murmurs. These may be early diastolic, mid-diastolic, or late diastolic or presystolic murmurs. Continuous murmurs. The shape or the configuration of the murmur is determined by its intensity over time. Grade the murmurs using the 6-point scale below the Levine grading system.